Welcome to the January 2018 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 4 scientific articles published in the January issues of the journal, as well as commentaries by Dr. H. Kerr Graham on the article entitled Long-Term Outcomes of Distal Femoral Extension Osteotomy and Patellar Tendon Advancement in Individuals with Cerebral Palsy, and Dr. Joshua Everhart on the article entitled Potential Sex Bias Exists in Orthopaedic Basic Science and Translational Research. Be sure to check out this month's Current Concepts Review article, The Antero-Posterior Pelvic Radiograph, Acetabular and Femoral Measurements in Relation to Hip Pathologies, by Dr. K. Linnea Welton and colleagues. The authors note that a proper technique is critically important for accurate interpretation of the antero-posterior radiograph, with a true antero-posterior radiograph of the pelvis made with the patient in the supine or standing position with a tube-to-image distance of 120 centimeters and a photon beam centered midway between the pubic symphysis and the top of the iliac crests. In this review, the authors describe the technical aspects of making a proper antero-posterior pelvic radiograph and how to assess the quality of the image. They discuss the various signs and measurements that can be derived from an antero-posterior pelvic radiograph, which can provide an overall understanding of hip and pelvic morphology. And they review how these different findings, when taken collectively, can aid in the diagnosis of common hip pathology, including, but not limited to, adolescent diagnoses, slipped capital femoral epiphysis, and Legg-Calvé-Perthes disease, hip dysplasia, femoral acetabular impingement, osteoarthritis, and osteonecrosis. In this issue, JBJS.org presents a new image quiz, a 61-year-old woman with swelling of the left elbow. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Long-Term Outcomes of Distal Femoral Extension Osteotomy and Patellar Tendon Advancement in Individuals with Cerebral Palsy, by Dr. Elizabeth R. Boyer and Associates. Investigation performed at Gillette Children's Specialty Healthcare, St. Paul, Minnesota. The authors examined long-term outcomes across the domains of the International Classification of Functioning, Disability, and Health for 2 groups of participants with cerebral palsy, who demonstrated crouch gait at clinical gait analysis. One group underwent a distal femoral extension osteotomy with patellar tendon advancement, DFEO plus PTA. The other group received other treatments, non-DFEO plus PTA. 51 participants returned for a long-term gait analysis, physical examination, energy consumption test, knee radiographs, and questionnaires. A subset of participants in the DFEO plus PTA group also had a short-term analysis. Participants were reasonably well matched at baseline, although the DFEO plus PTA group demonstrated greater crouch, minimum knee flexion, a median of 37 degrees compared with 27 degrees, and knee flexion contracture, a median of 15 degrees compared with 10 degrees. The gait deviation index and sagittal plane knee kinematics were most improved at short term for the DFEO plus PTA participants, with a subsequent slight decline at long-term analysis. Fewer DFEO plus PTA participants were in crouch at long term. At the long-term assessment, group scores for function, mobility, participation, quality of life, and most pain questionnaires were similar. Knee pain and osteoarthritis ratings did not differ between the groups. Conclusions. At long-term analysis, DFEO plus PTA improves stance phase knee extension and knee flexion contracture compared with conventional treatment. But these benefits do not translate to improved activity, participation, or knee pain in early adulthood. Next, you'll hear a commentary by Dr. H. Kerr Graham on the article entitled Long-Term Outcomes of Distal Femoral Extension Osteotomy and Patellar Tendon Advancement in Individuals with Cerebral Palsy.
This is Dr. H. Kerr Graham providing commentary for the January 2018 JBJS podcast. I will be providing commentary on the article entitled Long-Term Outcomes of Distal Femoral Extension Osteotomy and Patellar Tendon Advancement in Individuals with Cerebral Palsy. The title of my commentary is the Knee the Key to Long-Term Gait Function in Cerebral Palsy? Single-event multi-level surgery, SEMLS, consisting of multiple patient-specific soft tissue and osseous surgical operations, has become the standard of care to improve or maintain gait function in ambulant persons with cerebral palsy. Despite support from one pilot randomized controlled trial and numerous cohort studies, key questions remain unanswered. These include the effects of interventions before and after Semmel's, and the best method of achieving optimum dynamic knee function, especially correction of flexed knee gait. The long-term outcome study of distal femoral extension osteotomy combined with patellar tendon advancement, DFEO plus PTA, by Boyer and colleagues, is a major effort in understanding the interplay between this knee surgery and the effects of time, growth, previous and additional interventions on outcomes compared with more conventional treatment. It was not a perfect study design. A randomized surgical trial with long-term follow-up would have been superior, but also impossible on both ethical and practical grounds. However, the surgical technique for DFEO plus PTA has been developed and standardized by the Gillette Group. The follow-up was long-term, and the battery of outcome measures covered the spectrum of the International Classification of Functioning Disability and Health, or ICF. Furthermore, the comparison group, although not perfectly matched on baseline characteristics and surgeries prior to baseline, underwent procedures that are familiar to most surgeons. For many, this will be a useful and practical comparative study. The authors had three hypotheses, namely that DFEO plus PTA would result in better knee kinematics than conventional surgery, that DFEO plus PTA group would score better on questionnaires addressing ICF domains, and short-term gains in gait after DFEO plus PTA would be maintained. Only the first hypothesis was confirmed, which is an important finding. Perhaps the reason the two groups were not different in regard to ICF domains was the relapse in gait correction as shown by the gait deviation index at long-term follow-up. The authors suggest several other possibilities, including that the DFEO plus PTA group showed more severe involvement at baseline. The Americans with Disabilities Act levels the playing field in terms of activities and participation, and the natural history of cerebral palsy overpowers our interventions. These are all plausible explanations and are very important for all surgeons in this field to consider. However, the issue of prior gastrocnemius soleus complex lengthening may not have received sufficient attention. The body support moment which allows persons with cerebral palsy to maintain upright posture is contributed to by the ankle plantar flexors, the knee extensor mechanism, and the hip extensors. The majority of patients had prior lengthening of both the ankle plantar flexors and the hamstrings, thereby weakening two key muscle groups which might have contributed to a more extended posture at the ankle, knee, and hip. In addition, the DFEO plus PTA group had 3 times more injections of botulinum toxin A and more procedures prior to the baseline gait analysis than did the non-DFEO plus PTA group. In this regard, populations of persons with cerebral palsy attending gait laboratories in North America seem quite different from those in other parts of the world. In Australia, most patients with cerebral palsy presenting for gait analysis and Semmel's have had no prior surgery. Accordingly, the prevalence of iatrogenic flexed knee gait may be less. When it is present, it may be less severe, and it seems to be more amenable to long-term stable correction by less invasive surgery. It may be asking too much of DFEO plus PTA to maintain knee extension if plantar flexion knee extension coupling has been compromised by previous lengthening and weakening of the gastrocnemius soleus complex. The effects of impaired selective motor control may also have an impact on the persistence of flexed knee gait. In one center, an active campaign to prescribe isolated gastrocnemius soleus complex lengthening in children with diplegia was followed by a large, sustained reduction in the prevalence of severe crouch gait. Furthermore, in the children who later progressed to SEMLs, improvements at short-term follow-up were maintained at a mean of 9 years of follow-up. In these centers, DFEO plus PTA may be less frequently indicated. When it is utilized, patellar tendon shortening, or PTS, is a viable and simpler alternative to PTA. Patellar tendon shortening has become a safe and reproducible procedure with the advent of strong synthetic materials that are able to withstand the pull of the knee extensor mechanism. However, we know of no long-term studies of DFEO plus PTS. Boyer and colleagues are to be congratulated on a landmark study which will provide surgeons in the field with important lessons and much to consider in their practice of gait correction surgery for persons with cerebral palsy.
Next, you'll hear the second abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Randomized Trial Comparing Suture Button with Single Syndesmotic Screw for Syndesmosis Injury by Met Renat Anderson and Associates. Investigation performed at the Department of Orthopaedic Surgery, Bærum Hospital, Drammen, and the Division of Orthopaedic Surgery, Oslo University Hospital, Oslo, Norway. This study compared clinical and radiographic results between patients who underwent stabilization of an acutely injured syndesmosis with a suture button, SB, and those treated with one quadricortical syndesmotic screw, SS. 97 patients, 18 to 70 years old, with an ankle injury that included the syndesmosis, were randomized to 2 groups, SB and SS. The main outcome measure was the score on the American Orthopaedic Foot and Ankle Society, AOFAS, Ankle Hindfoot Scale. The secondary outcome measures were the Olrud-Molander Ankle OMA score, Visual Analog Scale, VAS, and Uruqual 5D, EQ5D Index, NVAS. Computed tomography scans of both ankles were obtained at 2 weeks and 1 and 2 years after surgery. Both groups were allowed partial weight bearing at 2 weeks and full weight bearing at 6 weeks. The mean time for SS removal was 85.9 days after surgery. The patients were followed at 6 weeks, 6 months, and 1 and 2 years. 2 years of follow-up were completed for 87 of the patients. The SS group had more injuries to the posterior malleolus than the SB group. At 2 years, the median AOFAS score was higher in the SB group than in the SS group, as was the median OMA score. The SB group reported less pain during walking at 2 years than the SS group and less pain during rest. There was no difference between treatment groups with regard to pain at night or during daily activities at 2 years. The SB group had a higher median EQ5D index score at 2 years. 20 of 40 patients in the SS group had a difference in the tibiofibular distance of greater than or equal to 2 millimeters between the injured and uninjured ankles at 2 years, compared with 8 of 40 in the SB group. 7 patients in the SS group had symptomatic recurrent syndesmotic diastasis during the treatment period, compared with none in the SB group. Conclusions. The patients treated with an SB had higher AOFAS scores, OMA scores, and EQ5D index scores, as well as lower VAS scores for pain during walking and pain during rest. Also, the SB group had less widening seen radiographically at 2 years than did the patients in the SS group. No differences in the scores for pain at night or during daily activities were identified. Next, you'll hear the third abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Potential Sex Bias Exists in Orthopedic Basic Science and Translational Research by Dr. Jessica Bryant and Associates. Investigation performed at the Department of Orthopedic Surgery, University of California, San Francisco, California. Potential sex bias has been shown in general surgery basic science and translational research with unequal representation of male and female specimens. Because basic science research forms the foundation for clinical studies on which patient care is based, it is important that this research equally consider both sexes. The purpose of this study was to determine if potential sex bias exists in the basic science and translational orthopedic literature. A systematic review was conducted of all articles published in 2014 in the Journal of Bone and Joint Surgery, Clinical Orthopedics and Related Research, the Bone and Joint Journal, and the Journal of Orthopedic Research, JOR. All original research articles utilizing animals, cells, or cadavers were included. The data abstracted included study type, sex of specimen studied, and presence of sex-based reporting of data. A second review was performed of all basic science articles published in JOR in 1994, 2004, and 2014 to compare sex bias trends across 3 decades. Distributions of variables were compared using the Fisher exact test, with significance defined as p less than 0.05. Of 1,693 articles reviewed, 250 were included, 122 animal-based studies, 71 cell-based studies, and 57 human cadaver-based studies. Overall, authors in 88 studies did not report the sex of animals, cells, or cadavers used. Of 162 studies in which the authors did report sex, 69 utilized male only, 40 utilized female only, and 53 utilized both sexes. Of those studies that used both sexes, authors in only 7 studies reported sex-based results. A sub-analysis of JOR articles across 3 decades revealed a significant increase in studies specifying sex from 2004 to 2014. Conclusions. Potential sex bias exists in orthopedic surgery basic science and translational research, with an overrepresentation of male specimens. Next, you'll hear a commentary by Dr. Joshua Everhart on the article entitled Potential Sex Bias Exists in Orthopedic Basic Science and Translational Research.
This is Dr. Joshua Everhart, providing commentary for the January 2018 JBJS podcast. I will be providing commentary on the article entitled Potential Sex Bias Exists in Orthopedic Basic Science and Translational Research. The title of my commentary is Why We Should Care About the Sex of Specimens in Cadaveric, Animal, and Cell-Based Orthopedic Research. As orthopedic surgeons, we are well aware of the important role that sex plays in the epidemiology and treatment of many orthopedic conditions. Some conditions have a strong bias toward men, such as Achilles tendon rupture, or women, such as Dacre vein tenosynovitis, and surgical treatment plans can also be influenced by sex. Using the knee as an example, women at the time of anterior cruciate ligament reconstruction are at a higher risk for an excessively small gracilis and semitendinosus combined autograft diameter. Women also tend to have relatively narrower distal parts of the femora in medial lateral dimension than men do, which in part led to the design of sex-specific implants for use in total knee arthroplasty. Historically, women have been severely underrepresented in human clinical trials, which led to the Revitalization Act of 1993 and the requirement to include women in clinical research funded by the National Institutes of Health, or NIH. Under this policy, enrollment rates of women in modern NIH-funded clinical trials are now higher than those of men. However, little attention has been paid to sex bias among animals or cells utilized in basic science research. In 2014, the NIH leadership unveiled future plans to roll out policies that require balanced use of male and female animals and cells in basic science research. The rationale for these proposed policies is that elimination of sex bias at the preclinical stage will lead to improved clinical study design and more reliable translation of results to clinical practice. This proposal has had mixed support in the basic science community. Routine use of male and female cell lines in animals, as well as comparison of experimental results by sex, may unnecessarily increase experimental costs and variability. If there is no physiologic basis for sex to play a role in certain experiments, why should it be investigated? However, proponents of the proposal suggest that the extra cost and effort needed to equally include male and female specimens are justified by the downstream costs of failing to do so, namely failed clinical trials, misdiagnosis and inappropriate therapies for women, and omission of fundamental biological principles. In the current review, Bryant et al. Investigated the potential for sex bias in orthopedic basic science research. The authors identified all cadaveric, animal, and cell-based studies shown in 4 of our top journals in 2014 and determined that sex is not reported in more than 1/3 of the included studies. Among studies that did include sex, there was a predilection towards use of male specimens, and authors reported sex-specific results in only 13% of studies that included both sexes. The predilection for male specimens in animal studies, in particular, is based on the unfounded and debunked assumption that variability in results is intrinsically higher in females because of variability in estrogen cycles. Clearly, we need to do a better job of consistently reporting sex in basic science research within our field. The current review highlights an important topic and reminds us to, at a minimum, actively consider the sex of specimens when interpreting study results or designing a new basic science experiment. Standardized reporting of the sex of included specimens should be a requirement, as well as an explanation for use of samples from one sex if a balanced sample of male and female specimens is not used. This has the potential to increase discovery of previously obscured sex-specific relationships and to improve the clinical applicability of basic science studies within our field.
Next, you'll hear the last abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Low Prevalence of Hip and Knee Arthritis in Active Marathon Runners by Dr. Danielle Y. Ponzio and Associates. Investigation performed at the Department of Orthopaedic Surgery, the Rothman Institute at Thomas Jefferson University, Philadelphia, Pennsylvania. Existing evidence on whether marathon running contributes to hip and knee arthritis is inconclusive. The author's aim was to describe hip and knee health in active marathon runners, including the prevalence of pain, arthritis, and arthroplasty, and associated risk factors. A hip and knee health survey was distributed internationally to marathon runners. Active marathoners who completed 5 or more marathons and were currently running a minimum of 10 miles per week were included. Questions assessed pain, personal and family history of arthritis, surgical history, running volume, personal record time, and current running status. Multivariable analyses identified risk factors for pain and arthritis. Arthritis prevalence in U.S. marathoners was compared with National Center for Health Statistics prevalence estimates for a matched group of the U.S. population. Marathoners with a mean age of 48 years ran a mean distance of 36 miles weekly over a mean time of 19 years and completed a mean of 76 marathons. Hip or knee pain was reported by 47%, and arthritis was reported by 8.9% of marathoners. Arthritis prevalence was 8.8% for the subgroup of U.S. marathoners, significantly lower than the prevalence in the matched U.S. population and in subgroups stratified by age, sex, body mass index, and physical activity level. 7 marathoners continued to run following hip or knee arthroplasty. Age and family and surgical history were independent risk factors for arthritis. There was no significant risk associated with running duration, intensity, mileage, or the number of marathons completed. Conclusions. Age, family history, and surgical history independently predicted an increased risk for hip and knee arthritis in active marathoners, although there was no correlation with running history. In the author's cohort, the arthritis rate of active marathoners was below that of the general U.S. population. Longitudinal follow-up is needed to determine the effects of marathon running on developing future hip and knee arthritis. Thank you for listening to this JB&JS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.